Good morning, everyone. Today, the topic for discussion is premature rupture of membranes. Coming to the definition, when the rupture of membrane occurs beyond 37 completed weeks of gestation, but it's before the onset of labor, it is called as term premature rupture of membranes. When it occurs before 37 weeks of gestation, it is called as a preterm premature rupture of membranes. If the rupture of membranes duration is more than 24 hours before delivery, it is called as prolonged rupture of membranes. Premature rupture of membranes, it usually occurs approximately in 10% of all the pregnancies, and it contributes to nearly 1/3 of the preterm births. The mechanism is usually the choriodecidual infection and the inflammation. They lead to a cascade of events which eventually results in leukocyte activation and release of cytokines and inflammatory mediators like interleukins, which result in premature cervical ripening and membrane rupture. The risk factors of premature rupture of membranes, it's same as preterm labor. Increased fragility of the membranes, polyhydramnios when the amniotic fluid index is more than 25 centimeters, cervical incompetence, multiple pregnancy, either twins or triplets, infections, chorioamnionitis, urinary tract infections like asymptomatic bacteria, pyelonephritis, and lower genital tract infections such as candidiasis. All these result in premature rupture of membranes. And the short cervical length when less than 2.5 centimeters, history of prior preterm births, and history of termination of pregnancy in the second trimester, the low body mass index of the patient which is less than 19 kg per meter square, smoking, also black race and low socio-economic status. All these conditions attribute to preterm premature rupture of membranes. Coming to the diagnosis, patient herself gives a history of a leakage of watery-like fluid from the vagina. So when there is a history of vaginal leakage of fluid, either as a continuous stream or as a gush, we usually get confused with these three conditions: hydraria gravidarum, incontinence of urine, and vaginal discharge. Hydraria gravidarum, it is a state where there is a periodic watery discharge which occurs probably due to excessive residual glandular secretions. So it is not pathological. And incontinence of urine. Incontinence of urine is usually intermittent, and you can elicit by asking the patient to cough, and you can see the urine dribbling from the urethra. And next, vaginal discharge. Vaginal discharge is usually mucoid and thick in consistency when compared to amniotic fluid, which is watery. And if the vaginal discharge is infected, it is usually associated with foul smelling and itching. So coming to the confirmation of diagnosis, you'll separate the labia and first ask the patient to cough, and then you can see a clear fluid dribbling within the vagina, or the sterile perspeculum examination is done to visualize the vaginal pooling of this amniotic fluid. It is a clear fluid which can be seen coming out from the cervical canal. And the test to confirm whether it is amniotic fluid: detection of the pH by the litmus paper or the nitrazine test, it is called. Here the normal vaginal pH during pregnancy is usually 4.5 to 5.5, whereas that of amniotic fluid is 7 to 7.6. So when there is amniotic fluid, the nitrogen paper turns from yellow color to blue. As the pH of the amniotic fluid is more than 6, you can see this. The main principle behind this nitrogen test is pH of the vaginal secretions and the urine is acidic, whereas that of the amniotic fluid is alkaline. So there is a change of color from yellow to blue. But with this, we can also see false positive results, which is due to the presence of blood or some vaginal infections. There can be errors as well as false positive results. The other is test is by noting the characteristic pattern when a smeared slide is examined under the microscope. It's called as a Fern test. This ferning pattern is usually seen because of the crystallization of the sodium chloride on the mucous fibers under high estrogen concentration. And also, in addition to this ferning test, if the slide which is being examined under the microscope, the slide is dried and it is heated, then the slide turns into white color if it has amniotic fluid. If there is no amniotic fluid, then the color change will be brown. Also, centrifuge cells stained with 0.1% of Nile blue sulfate, which show orange-blue coloration of the cells. It's the exfoliated fat-containing cells from the sebaceous glands of the fetus. Usually, all these tests are not done. The basic thing which we do is sterile perspeculum examination has to be done to find out whether it is amniotic fluid which is coming from the cervical os. Next is ultrasound examination. Confirmation of these ruptured membranes is usually accompanied by the sonographic examination, which is done to assess the amniotic fluid, which may attribute to oligohydramnios if there is a premature rupture of membranes. Here you can see the ferning pattern when the slide is examined under the microscope. And there is also a new test which is a immunochromatographic method, that is Amnisure. It is used to detect trace amounts of placental microglobulin 1. This placental microglobulin 1, it is a protein which is produced by the cells of the residual part of the placenta. This can be detected in amniotic fluid after rupture of membranes. It is a sensitivity of around 99% and specificity of around 100%. Other routine investigations which we do is complete blood picture. Apart from hemoglobin, you can see the WBC count, leukocyte count, if there is any leukocytosis to rule out chorioamnionitis, urine for routine culture and analysis. Also, high vaginal swab is taken for culture prior to vaginal examination. And also ultrasonography for fetal biophysical profile and the non-stress test. Coming to the management of premature rupture of membranes, preliminaries we need to be followed are aseptic examination has to be done if being performed, advised bed rest to the patient. Once the diagnosis has been confirmed, the management depends upon the gestational age, whether the patient is in labor or not, to rule out evidence of any infection, sepsis, and post-delivery the prospect of the fetal survival, and also the vitals should be monitored. And if the patient is remote from term, usually conservative management is to be advised after examining the patient to rule out evidence of cord prolapse, cord compressions, fetal abruption, and fetal distress. Also, we need to evaluate for symptoms of clinical chorioamnionitis such as lower abdominal pain, vaginal discharge with foul smelling, fever, and malaise. Clinical assessment of the patient has to be done by examining the pulse rate, if there is any tachycardia, the blood pressure, temperature, and the maternal blood test to be done are C-reactive protein and the leukocyte count. And the fetal heart rate should be checked to diagnose chorioamnionitis in the woman with premature rupture of membranes. And when chorioamnionitis features are not there, and when evidence of cord prolapse, cord compression, placental abruption, fetal distress, if they have been ruled out and you're going for conservative management, then avoid pervaginal examination, do perspeculum examination, and then let the labor progress. Antibiotics. Prophylactic antibiotics are given to minimize the maternal infections and the perinatal risk of infections. Usually, antibiotics are more effective in preterm premature rupture of membranes, less than 32 weeks of gestation. Use of antibiotics is usually associated with significant reduction in chorioamnionitis and also decreases the number of babies born within 48 hours to 7 days. It reduces the neonatal infections. Use of surfactant for the baby. Also oxygen therapy. An abnormal cerebral scan which is done prior to discharging the baby from the hospital after delivery. And usually the antibiotic of choice is erythromycin. Dosage is 250 milligrams 4 times a day for 10 days. Penicillin can be given if the woman is allergic to erythromycin. So apart from erythromycin, ampicillin 2 gram IV stat followed by 1 gram IV every 12th hourly can be given. But avoid amoxicillin or clavulinate combination because it increases the risk of necrotizing enterocolitis in the neonates. Corticosteroids to be given because to accelerate the fetal lung maturity as in the case of preterm premature rupture of membranes. It is advised from 24 to 35 plus 6 weeks of gestation. Short-term tocolysis can be considered for administration of steroids and antibiotics and also for maternal transport in the case of where NICU facilities are available in such places for the tertiary to shift the patient to the tertiary hospital. In such cases also short-term tocolysis can be advised. Usually steroid therapy is not advised or recommended before 24 weeks. The dose of steroids which we use, betamethasone 12 milligrams intramuscular 24 hours apart, 2 doses are given, or dexamethasone 6 milligrams intramuscular 12 hours apart, total 4 doses. And apart from antibiotics, steroids, also magnesium sulfate, which is for neuroprotection. It is effective between 24 to 32 weeks of gestation. It decreases the risk of cerebral palsy and also the motor dysfunction in the neonate. The dose which is given is 4 grams IV loading dose followed by an infusion of 1 gram per hour until birth or 24 hours. Whichever is earlier, that is followed. Fetal surveillance is done by the biphysical profile and the non-stress test. So delivery must be planned whenever there is evidence of clinical infection, and we can go ahead with normal delivery, and cesarean is indicated for obstetric indications usually. And other indications for terminating the conservative management is non-reassuring NST, or if the pregnancy has reached 34 weeks. PPROM between 34 to 36 weeks is usually controversial. Once the fetal maturity or the steroid coverage has been done, then the labor, then she can be planned for delivery. Because chorioamnionitis, though it is asymptomatic, I mean no clinical features are seen, or there's no evidence of leukocytosis or raised C-reactive protein, but asymptomatic documentation on histology is reported in nearly 50%, and also associated risk of cerebral palsy to the baby would also be there. So once 34 weeks has been reached and PPRM is there, then you can plan for delivery. So preterm premature rupture of membranes. Ideally, the patient should be transferred with the fetus in utero to a setup where there is a good NICU facility to manage preterm neonates. So if the gestational age is 34 weeks or more, perinatal mortality or from prematurity is usually less. Labor generally starts spontaneously within 48 hours. If not, induction is done with misoprostol or augmentation of labor with oxytocin. When the gestational age is less than 34 weeks, then conservative management can be followed only in the absence of chorioamnionitis, as well any fetal indications are not there for terminating. Here you can see a flow chart in the management of premature rupture of membranes. First, when the patient comes in, maternal health assessment has to be done. Shilpa. Maternal health assessment of her pulse rate, blood pressure, temperature. General examination has to be done, and assess the fetus with the gestational age, weight, and the pulmonary maturity. You should prior to doing the pervaginal examination, you should do a perspiculum examination and then take a cervical swab for culture sensitivity, and non-stress test and biphysical profile is done. And monitor the pulse rate, temperature, fetal heart rate, and start on prophylactic broad spectrum antibiotics, and accordingly steroid coverage is done. Following it, assess for chorioamnionitis, placental abruption, fetal distress, as well labor process. If these are present, then you should plan for delivery, and the baby is handed over to pediatrician. If there is absence of chorioamnionitis, placental abruption, fetal distress, and the patient is not in labor, then in such cases, if the pregnancy is more than or equal to 37 weeks, wait for spontaneous onset of labor for 24 hours. If that fails, induction of labor is done. And cesarean section is only for obstetric reasons, or if there is any fetal distress. Pregnancy between 34 to more than or equal to 34 to less than 36 weeks. Here also wait for spontaneous onset of labor for 24 hours. If it fails, induction of labor with oxytocin, and cesarean for obstetric indications is planned. Pregnancy less than 34 weeks, expected management to continue for fetal maturity is done, and in utero transfer of the fetus to a center where there are adequate NICU facilities. Bed rest, antenatal steroids, broad spectrum antibiotics are given to prolong the pregnancy, as well to reduce the infectious morbidity. So serial evaluation and follow-up is considered, and deliver at 34 weeks if possible. Complications of premature rupture of membranes. It results in preterm labor and prematurity. Chorioamnionitis from the ascending infections if it is more than 24 hours. And risk of cord prolapse when it is associated with malpresentations. Continuous drainage of liquor for a long duration leads to dry labor. And maternal complications like placental abruption, retained placenta, postpartum hemorrhage, and endometritis. It also results in neonatal pneumonia, sepsis, respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis in preterm premature rupture of membranes. Perinatal morbidity, mainly cerebral palsy, is high in preterm premature rupture of membranes. Preterm premature rupture of membranes with inflammation is usually associated with increased risk of neurodevelopmental impairment and neonatal white matter damage. Thank you.